In this video, we're going to discuss coping and social support. So remember from a previous video when we talked about stress appraisals and I explained Lazarus's theory about how people can respond when they're confronted with a stressor? If you remember, first, they make a primary appraisal. So is the stressor positive, negative, or neutral? If they decide it's positive or neutral, they feel no stress and the appraisal process is over. If they decide that it's negative, then they have to decide whether it's harmful, threatening, or challenging. Then they make a secondary appraisal. Can I cope with the demands of the stressor, which is either harmful, threatening, or challenging? Well, in this video, we're going to talk about the coping part of that equation. The official definition of coping is a dynamic series of transactions between the individual and the environment, the purpose of which is to regulate internal states and/or alter the person-environment relations. Okay, so that's a bit confusing. So read, acknowledge, and then forget this definition, because I know that you all know and understand what coping is, because we all do it all the time. Here's a better definition. Coping refers to cognitive, emotional, or behavioral efforts to manage the demands of a stressor. I want to highlight the word efforts in this definition. So even if an individual's efforts to cope are unsuccessful, their behavior still counts as coping. I'll say that again. Even if you try to cope and fail, that behavior is still considered coping. Some coping efforts will succeed, and others simply won't. There are 4 goals or functions to coping. The first function of coping is to master or eliminate the distress-inducing problem. For example, trying to wake up in the morning when you know you have to hurry up and get going. You can temporarily eliminate the distress-inducing problem by hitting the snooze button on your alarm. The second function of coping is to alter your appraisals of the distress-inducing situation. So, for example, you can remind yourself that by waking up, you can go grab some coffee. The third function of coping is to reduce psychological and physiological distress reactions. So, for example, when some people wake up in the morning, they stretch first thing, and this to some extent reduces the unpleasantness of waking up. And then finally, the fourth function of coping is to return to normal or better functioning. So by turning off the alarm and hopping out of bed, you can start your day and get your day going. One way to categorize coping strategies is by distinguishing between emotion-focused and problem-focused coping strategies. Emotion-focused coping strategies refer to doing something that makes you feel better about your situation. You're trying to alter your emotions that are caused by the distress-inducing event. Problem-focused coping refers to efforts to solve or alter the stressor. In this case, Charlie thinks that some people might experience stress because their cats are too noisy. To help people solve this problem, he invented kitten mittens. Another way to categorize coping strategies is by distinguishing between active and avoidant coping strategies. Active strategies are efforts intended to do something about a stressor or its emotional consequences. Avoidant strategies refer to attempts to withdraw or ignore a stressor. Now we can put all those together and talk about emotion-focused active coping and emotion-focused avoidant coping, as well as problem-focused active coping and problem-focused avoidant coping. Emotion-focused active coping involves active efforts to confront the emotions the stressor arouses. there are two parts to emotion-focused active coping. First is the processing of your emotions about the stressor to kind of figure out how you feel about the stressor. The second part of the emotion-focused active coping strategy is expressing those emotions. Emotion-focused avoidant coping involves denying and avoiding how the stressor makes you feel. So, for example, you might convince yourself that you're not really as upset about something as you really are. Problem-focused active coping involves active efforts to solve or alter a stressor. This is probably what most people think of when they think of coping strategies. Problem-focused avoidance is kind of the weirdest combination. This would be efforts to solve or alter the stressor by avoiding or withdrawing from it. I think about this as having some time-sensitive decision to make and then letting enough time go by that the decision's eventually made for you. So, which coping style is best? In general, there is no right or wrong coping style, except that coping by doing something dangerous or unhealthy, such as getting really drunk, isn't going to lead to very good outcomes. So beer might be cheaper than therapy, but it's probably not the best way to cope with stressors. Some coping techniques are better suited to certain situations. If it's a situation that you have some control over, then problem-focused or active coping techniques will probably work best. Stressing over an upcoming exam is a great situation for problem-focused or active coping because you have control over how much or how little you study. If you can't control the situation, you're better off with emotion-focused or avoidant coping strategies. Things like stressing over the economy, things like that are better served by emotion-focused or avoidant coping techniques because you don't have any control over how well the entire U.S. economy is doing. Also, time frame can make a difference for which coping style may be better. For short-term stressors, avoidance coping may be better. Stressing over being stuck in traffic may be best served by avoidance coping. Simply thinking about something else may be best because you won't be stuck in traffic forever. For long-term stressors, active coping would be better. For example, if you learn you're moving to a new area of the city known for having really bad traffic, you can think ahead and plan a new route to school to avoid the traffic. Stanton and his colleagues looked at the effects of a particular type of coping with cancer. They focused on emotion-focused active coping, which is the kind of coping where you try to understand your emotions and then express your emotions. In this study, they followed 92 breast cancer patients who had just finished their treatments. At the beginning of this study, they surveyed the women on how much emotion-focused active coping they were using, and they measured both types of emotion-focused active coping, both emotional processing, where they try to understand their feelings, and emotional expression, where they try to express those feelings. And then the researchers followed the women for 3 months and measured how distressed they felt. They also assessed the women's physical health. They found that the more emotional processing the women were doing at the beginning of the study, the more distressed they were 3 months later. So emotional processing coping wasn't really helping them. But the story's a bit different for emotional expression coping. They found that the more the women expressed their emotions at the beginning of the study, the less distressed they were 3 months later. Additionally, they found that the more the women were expressing their emotions at the beginning of the study, the better their physical health was 3 months later, according to self-reports, the fewer follow-up medical appointments they needed, and the healthier they perceived themselves to be. So overall, it seems like expressing was better than processing. So that study is exciting, and that it suggests that coping strategies can do more than just reduce your stress. They can also improve your physical health. Let's turn now to social support, which many people think of as a coping technique in its own right. But what is social support? Social support is any kind of interpersonal interaction involving A, emotional support, so showing concern, helping others feel better about themselves, or helping others to feel understood. So, for example, if you know someone who you can talk to or who can comfort you if you are upset, this would be an example of emotional support. B, belonging support. So having people to do things with, just hanging out and making stuff that makes you feel connected, basically. So, for example, if you decide to take a study break and go to the movies with a friend. C, tangible support. This is providing direct aid. So, for example, lending someone money or babysitting are examples of tangible support. And D, informational support, which is just getting good advice from other people. So, for example, having somebody you could talk to if you were having issues adjusting to college life. That person could give you advice on how to kind of settle into your collegiate career. When we talk about social support, we need to be clear on which aspects of social support we're talking about. There are three broad aspects to social support. One involves social integration versus social isolation. If you have social relationships, you're integrated. If you don't, you're isolated. A second broad aspect involves properties of your social network. Basically, what are the characteristics of your social relationships? How many do you have? How often are you in contact with your friends? A third aspect of social support is the function of your social network, which means what do the relationships do for you? Do they provide different kinds of social support, or do they make demands on you and cause conflict? Okay, moving on to one more aspect of social support, and then we'll discuss some studies examining links between social support and health. There's one final distinction that we need to make, and that's between perceived and received support. Perceived support is the amount of support that you believe exists for you in your social network. It's your perception that help will be there for you if you need it. Received support, on the other hand, is the actual amount of support that you really experience. This is sometimes called objective support, experienced support, or actual support. One stressor that health psychologists are very interested in is serious illness, and in particular, cancer. Cancer is particularly difficult to adjust to because it's potentially fatal, it's often characterized with stigma, and it can involve some really unpleasant treatments. Not to mention, it may challenge your beliefs about the world, leaving you feeling vulnerable or lacking control and confused. An early study on social support in breast cancer survival suggests that increased emotional support may be beneficial. Spiegel and colleagues conducted a study to determine whether an intervention they were doing was effective. They randomly assigned women to either be in a support group or be in a waitlist control group. The group met once a week for a year in 90-minute sessions. During these sessions, the group members discussed their feelings about their illness and the effect their illness had on their lives, including any physical problems such as side effects from chemotherapy. The women in the intervention group developed strong bonds with each other, in other words. The researchers followed up with their patients for 10 years. They found that women who were in the support group lived an average of 18 months longer than women who were in the waitlist control group. On the x-axis is the number of months the women had been in the study. The y-axis is the probability of survival. You can see that in both groups, the women's likelihood of survival gets smaller as the months go on. However, the women in the treatment group had a more gradual decline in their probability of survival, whereas the women in the control group had a rather steep decline. There's something about the therapy group that helped the women live longer. However, we're not really sure what that was because these researchers didn't study that directly. A more recent meta-analysis has been conducted. Remember, a meta-analysis is simply a study that looks at multiple similar studies to determine if the results all support the same conclusion. This particular meta-analysis focused on 4 separate studies, including the one I just discussed. All 4 studies had an intervention group, which involved some form of support group therapy, and a control group. Also, among the 4 studies, there's a mix of different forms of cancer at different stages. The intervention involved a weekly supportive group meeting, which lasted from an hour to 2 hours, depending on the study. Additionally, the weekly meetings were held anywhere from 8 weeks to a full year. The researchers followed up with their patients for 5, 6, or 11 years. 3 out of the 4 studies showed no significant differences in lifespan between the intervention and control groups. Only the first study we just talked about by Spiegel and colleagues showed any significant improvement. So based on this meta-analysis, the evidence is pretty mixed and not really looking very good for support of the hypothesis that emotional support increases the lifespan of individuals with cancer. Even though the meta-analysis doesn't provide good evidence for the benefit of interventions regarding lifespan, this doesn't mean that the interventions don't do any good at all. Interventions that don't find increased lifespan often do find great psychological benefits to the support groups. So, for example, consider a study conducted by Goodwin and colleagues. They did an intervention very similar to the one by Spiegel and colleagues. 235 women with breast cancer were randomly assigned to an expressive supportive group or a control group. In the expressive supportive group, the women were given the opportunity to speak about the effects of the illness and its treatment. These women also discussed the changes in their self-image, their roles, and their relationships with family members, friends, co-workers, healthcare providers, and others. The women also discussed strategies for coping and communicating. Although there was no significant difference in mortality between the intervention and control groups, there was a difference in psychological adjustment. Based on self-report measures, women in the intervention group felt less pain and distress than women in the control group. And that's what these graphs are showing you. In both graphs, the x-axis is time and the y-axis is showing a change score. Basically, a change greater than 0 indicates an increase in distress or pain, and a change less than 0 indicates a decrease in distress or pain. The top graph shows that women in the intervention group decreased in their level of distress compared to the control women, and the bottom graph shows that women in the intervention group also had a decrease in their pain levels compared to women in the control group. So overall, the research seems to suggest that support groups don't really appear to increase overall lifespan, but do improve psychological adjustment. Now, moving on from chronic illness, let's take a look at some of the evidence that social support is good for your general health. Researchers have found associations between social relationships and health. Overall, socially isolated people tend to get sick more often and die at younger ages than people with large social networks. But the study in this area of health psychology is forced to rely on correlation, so it can be difficult to really interpret the results. For example, it could be that social relationships keep people healthy, and lacking those relationships causes people to get sick. But it may also be that healthy people are better able to form close relationships, whereas sick people can't. Or perhaps this could be due to a third variable. Perhaps there's some kind of personality trait that leads people to both get sick and lack friends. So, for example, hostility. One study was able to get around the reverse causality issue of whether some people are too sick to have friends. They looked at whether terminally ill people were visited by a volunteer hospice worker, which could happen whether or not they had friends. They examined the medical records of terminally ill patients who were living at home and not receiving any curative treatments anymore, which is what hospice care is. These patients were allowed to request that a volunteer from the hospice visit them occasionally. The researchers divided the patients into 3 groups: those who requested a volunteer and the volunteer actually visited them, those who requested a volunteer but through some scheduling problems they were never actually visited, and those who did not request a volunteer. In their analyses, the researchers made sure to control for baseline health, disease type, and demographics. What they found was that the patients who requested and were actually visited by a volunteer lived on average 80 days longer than patients in the other 2 groups. This group shows the percent of patients still alive at each time point. The x-axis shows you the number of days since the patient entered hospice, and the y-axis shows you the probability of survival. The white dots are the patients who asked for a volunteer but didn't receive one. The black dots are the patients who didn't ask for a volunteer, and the gray dots are the patients who did receive a volunteer. So you can see that the patients who had a volunteer visit were more likely to be alive at each time point, with the overall result being that they lived longer. But to add a wrinkle to the story, another study was conducted to further investigate the relationship between social support and colds in the real world. Previous studies where they lock people away and expose them to cold viruses are very useful for showing causal connections between variables, but they don't say much about what actually goes on in the real world. And one thing that's true about the real world is that the more people in your social network, the more colds you're going to be exposed to, since you're going to be interacting with more people. So in this study, researchers had 114 healthy college students. They surveyed them on how many stressful life events they had experienced over the past 12 months, and the participants also filled out information on the diversity of their social network. To measure that, the researchers listed 12 types of social relationships, and the participants checked off whether they spoke to someone who had that kind of relationship with them at least once every 2 weeks. Now note that this gets at the diversity of social networks, because you get 1 point for each type of relationship, ignoring the size of your social networks, because you could easily have many people within any one category. During the 12-week time period, subjects completed diary entries concerning cold symptoms. If they thought they might have a cold, they went into their healthcare center to have their symptoms verified. The findings were pretty interesting. The x-axis is showing you participants' social network diversity, with low diversity on the left and high diversity on the right. The y-axis shows you the percentage of subjects within those groups that got a cold, verified by a nurse. The white bars are subjects who had few stressful life events, so 0 or 1, and the black bars are subjects who had many stressful life events, so 2 or more. The subjects who got the most colds were the ones with highly diverse social networks, and also a lot of stressful life events. This probably means that their immune systems were compromised by all their stress, and they were also exposed to a lot of different colds. The subjects who got the fewest colds were the ones with highly diverse social networks, but not as many stressful life events. These subjects were exposed to a lot of different colds, but their immune systems weren't compromised by any kind of stress, so they didn't come down with any colds. The subjects with less diverse social networks fell somewhere in the middle, which makes sense if you imagine that they're not getting exposed to many colds in the first place, so their immune systems can fight them off, even if they're compromised from stressful life events. So these findings add another component to this area of research. Social networks can lead to poor health as well as good health, mainly by simply exposing you to more illnesses, which you might not be able to fight off. To really get a sense that social support causes better health, rather than just being associated with it, you need to conduct true experiments. And lucky for us, there have been many. I'm going to tell you about two of them. First, a lab study, and then a field study. In the lab study, subjects had to do a stressful activity. They had to engage in a debate that they were not particularly well prepared for. In both conditions, there were three Confederates. A Confederate is a subject who's actually part of the study, unbeknownst to the actual subject. Two of the Confederates would argue with the subject. In one condition, the third Confederate would defend the subject, so this would be the social support condition. In the other condition, the control condition, the third subject would just sit silently, so the participant didn't receive any social support in this condition. This graph shows the main results. The x-axis shows the number of minutes into the discussion, and the y-axis shows heart rate change and blood pressure changes. The white dots are the participants without support, and the black dots are the participants who received social support. Without the supportive person present, subjects showed a typical stress response in terms of heart rate and blood pressure. But with the supportive person present, the black dots, the heart rate and blood pressure changes were much less significant. Further research found two important caveats to this story. So what if the supporter is evaluating you? So you're being supported, but also evaluated by the individual. If this is the case, we don't get this kind of buffering effect with regard to stress responses. So social support only helps if the supporter is simply supporting you and not evaluating you in any way. What's more is that when the supporter is a dog, this stress buffering effect works even better. People show even less stress when the supporter is a dog, probably because obviously your dog isn't evaluating you. Makes you wonder how well this would work if you had a cat supporting you. This begs the question, what potential mechanism drives these effects? New research has been conducted that links social support, health, and one potential mechanism for the relationships between social support and health. Remember, in a previous video when we discussed stress and health, we talked about telomeres and the role they have in the aging process. I showed you this slide and told you that telomeres basically are both an indicator and a cause of aging. Well, these researchers investigated how telomere length may be related to social ties and health. They looked at 136 relatively healthy subjects who were between the ages of 48 and 77. This age range was to help give them differing telomere lengths among their participants. Subjects came to the lab and filled out questionnaires regarding their health, their perceived stress, their number and types of social relationships, and their interpersonal support. Afterward, they had some blood drawn so that the researchers could measure telomere length. These researchers found that participants who had more ambivalent social relationships, ambivalent meaning relationships with a mix of positive and negative attributes, had the shorter telomeres compared to the other participants. Additionally, the number of supportive, positive social ties wasn't related to telomere length at all. However, these researchers found that there was a gender difference, which is what's indicated by this graph. For men, there actually is no significant relationship between ambivalent social ties and telomere length. However, the relationship is significant for women. So the y-axis is telomere length, and the x-axis shows low versus high ambivalent ties. So for women, low ambivalent ties is associated with longer telomeres, and high ambivalent ties is associated with shorter telomeres. These researchers suggest that individuals with poor social connections end up with shorter telomeres. These shorter telomeres then are the cause of the poor health outcomes that we've discussed. This is seen as an especially important finding since studies have found that shorter telomeres can predict cancer incidence, mortality, and advanced cardiovascular disease risk. Although these results are pretty cool, they're still correlational, so we can't really say anything about causation. So far, we've talked about the fact that sport affects health, and we've talked about one study that suggests a potential mechanism behind this relationship. But what does theory have to say about how social support might affect health? Well, there are three theoretical models used to explain how support might affect health. One is the direct effects model, which states that social support leads directly to better health outcomes by altering some aspects of our physiology, cardiovascular function, endocrine function, or immune function. Another is the buffering model, which states that social support moderates the relationship between stress and health, preventing stress from doing its damage. It may do this by decreasing how stressful an individual finds an event to be. So, for example, a person with lots of social ties might feel less job stress because their friends provide them with helpful information or reaffirm other aspects of the person's life. Lastly is the health behavior model, which states that social support might lead people to engage in more healthy behaviors. Perhaps because friends and family may pressure you to take better care of yourself and behave in healthier ways, or maybe because having close friends and family may make you feel loved and thus motivate you to take better care of yourself.